Hi there, my highly valued, appreciated and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services, so I humbly urge you to sit back and spare me part of your very precious time to share with you some very precious tips which may prove useful in your line of duty. I welcome you to part 66 of our Pharmacotherapy MCQ series, which majors in psychiatry. And our first question reads, Mr. COC, a 37-year-old male, was recently initiated on varenicline for smoking cessation at your hospital's psychiatry clinic. Today, he presents to the clinic complaining of cravings of cigarettes despite being fully compliant with his varenicline therapy. So my question to you is, which of the options listed below would be the next best course of action in Mr. C or C's case? Would you opt to discontinue varenicline and start nicotine gum as needed, or that is PRN? Or would you add nicotine gum to his regimen? Or would you add clonidine to his regimen? Or would you add bupropion to his regimen? I'll give you 10 seconds to choose the correct answer. So I would choose to add nicotine gum to his regimen. I would like to emphasize that varenicline is a first-line agent for smoking cessation, which can be combined with nicotine replacement therapy, which from now on will be abbreviated as NRT. I would like to remind you that NRT may be added to varenicline in patients who don't adequately respond to varenicline alone. Now, while there is a risk of excessive nausea, vomiting, headache, dizziness, and dyspepsia, the risk appears to be low, so we can overlook that. And I would like to add that the addition of bupropion to varenicline isn't recommended by the American College of Cardiology guidelines, the ACC guidelines for smoking cessation. Now, if the agent alone isn't reaching the target outcome, that is, if either bupropion or varenicline isn't reaching the target outcome, combination NRT should be used prior to switching agents. That is, you should add on an NRT. Now, while the addition of clonidine to varenicline may be reasonable, the most appropriate intervention at this time, in my opinion, would be to add NRT. I would like to add that while varenicline is the first line for smoking cessation, combination NRT is a reasonable alternative. However, combination NRT is defined as a continuous nicotine dose, such as the nicotine patch, with the addition of a PRN nicotine for breakthrough cravings. Now, the PRN form may be the gums, the lozenges, or even nicotine spray. Therefore, in my opinion, discontinuing varenicline for nicotine gum wouldn't be appropriate. appropriate. So that's just to justify why B, in my opinion, is the correct answer. Let's move to the next slide, please. And the question reads, Mrs. AJO, an 85-year-old female, presents to your clinic with a chief complaint of being unable to fall asleep at night. During the previous clinic appointment, she was initiated on escitalopram at a dose of 10 milligrams once daily for anxiety and depression. Currently, she takes atorvastatin at a dose of 20 milligrams at bedtime, lisinopril at a dose of 40 milligrams once daily, 120 milligrams of diltiazem SR once daily, and 10 milligrams of donepezil once a day. She informs your clinical team that escitalopram has improved her mood, though she occasionally still has nights when she can't, in her own words, turn off her brain, and she lays awake worrying. She informs the team she has tried improving her sleep hygiene and also used melatonin. Today, she requests a medication that she can use as needed, that is PRN, for sleep disturbance. So my question to you is, in addition to increasing her escitalopram dose, which of the medications listed below would you recommend for temporary adjunct treatment for Mrs. AJO's anxiety-related sleep disturbance? Would it be diazepam, lorazepam, triazolam, or alprazolam? I'll give you 10 seconds to choose the correct answer. So I would opt to add lorazepam to her regimen. Now, in the geriatric population, benzodiazepines should generally be avoided, but they may be used as a temporary adjunct for anxiety or depression-related sleep disturbances with an antidepressant. Benzodiazepines may impair memory, they may increase the risk of falls, fractures, and even respiratory depression in this geriatric population, such as in this lady's case. I would like to add that lorazepam is a short-acting benzodiazepine, and it doesn't undergo phase 1 metabolism. It is also available in small doses, and that makes it a preferred choice for inducing sleep in the geriatric population. Alprazolam, which is alternative D, on the other hand, is a long-acting benzodiazepine and would be associated with more adverse effects. It should therefore be avoided in the elderly population. It is also a CYP3A4 substrate and therefore may cause many drug-drug interactions, so I would not opt for it. And alternative C, triazolam, is a short-acting benzodiazepine and it undergoes CYP3A4 metabolism. I would like to remind you that Madam AJO is on other CYP3A4 substrates such as atorvastatin and diltiazem. Remember, diltiazem is also a CYP3A4 inhibitor, so it would have drug-drug interactions with the triazolam, so I wouldn't go there either. Now, diazepam is a long-acting benzodiazepine and it would be associated with more adverse effects. It should be avoided in the elderly, and if I remember well, it's also a substrate of CYP3A4 and therefore may cause many drug-drug interactions. So just like to emphasize that in the geriatric population, benzodiazepines should generally be avoided, but may be used as a temporary agent for anxiety of depression related sleep disturbances with an antidepressant. I would like to underscore the fact that escitalopram or sertraline are generally preferred over other SSRIs in the geriatric patients because of the fact that they have more favorable pharmacokinetic profiles, fewer adverse drug interactions, and less risk of adverse drug effects. Let's move to the next slide, please. And the question reads, as the clinical pharmacist in the psychiatric clinic, you are consulted for recommendations for a male patient engaged in a smoking cessation program. This patient has been taking bupropion with combination nicotine replacement therapy, abbreviated as NRT, for the past 7 months. Now, this patient seeks to know if therapy can be continued. So my question to you is, which of the responses below would be the most accurate for this patient's query? Would you recommend the addition of varenicline? Would you recommend continuation of NRT until the patient is confident that he will not relapse or return to smoking? Or would you recommend discontinuation of bupropion and NRT immediately? Or would you recommend continuation of NRT up to a year? I'll give you 10 seconds to choose the correct answer. So I would recommend continuation of NRT until the patient is confident that he will not relapse. Now, according to the American College of Cardiology, what we abbreviate as the ACC smoking cessation guidelines, although NRT therapy is typically continued for up to 12 weeks, the patient may continue NRT until they are confident that they won't relapse or return to smoking. I'd like to emphasize that no harm from long-term NRT use has been reported in literature. Therefore, recommending that the patient continue NRT until they are confident that they will not relapse is the most appropriate response, in my opinion. Additional inquiry may be necessary to ensure that the patient understands the appropriate administration methods and counseling points to ensure that there are no patient education factors that are leading to prolonged NRT. I would also like to add that bupropion may be continued for up to 12 months with or without NRT. Therefore, discontinuing therapy at 7 months without any other compelling reasons to discontinue the bupropion isn't appropriate. So not go for C. Then I would like to add that combination varenicline may be combined with NRT, but it shouldn't be combined with bupropion. That is not appropriate. Now, NRT shouldn't be avoided in patients with cardiovascular disease. I'd like to add that no NRT agent has been associated with increased adverse cardiovascular events at all in literature. So let's move to the next slide, please. The question reads, which of the statements listed below correctly distinguishes delirium from dementia? Is it true that delirium is reversible while dementia is not? Is it true that dementia isn't reversible and correctable? Is it true that dementia is always correctable, or is it true that dementia is always reversible? I'll give you 10 seconds to choose the correct answer. So the correct answer is dementia isn't reversible and correctable. Although the characteristics, signs, and symptoms of dementia are like those of delirium, dementia differs from delirium in that dementia isn't reversible and correctable. And delirium is sometimes reversible and correctable when the underlying disorder that is causing the delirium is corrected. I'd like to add that delirium and dementia are common causes of cognitive impairment in older populations, in the geriatric patients. Now, although each may occur independently, they frequently coexist in patients. I'd like to emphasize that dementia is a leading risk factor for delirium, and there is an increased incidence of new dementia and cognitive decline after delirium. I would also like to add that apathy has also been associated with an increased risk of dementia. Now, although preventative measures to prevent dementia aren't fully understood, some clinicians believe that dementia can be prevented by treating and controlling hypertension. It can also be treated with consistent daily physical exercise, with good nutrition, and maintaining a sharp and active mind with things like, for example, the brain games and even memory exercises. So those are just by the ways. Let's move to the next question, please. And it reads, Mr. BZO, a 47-year-old male patient, is purchasing an over-the-counter nicotine gum product as part of a smoking cessation attempt. He would like to use the gum product, but is uncertain of the difference between chewing gum and nicotine gum. So my question to you is, which of the statements listed below would be the most appropriate counseling point for Mr. BZO now? Would you recommend he choose similar to any chewing gum? Or would you recommend he choose the 4 mg gum since he smoked more than 25 cigarettes daily? Or would you recommend he drinks coffee or soft drinks while chewing gum to enhance absorption? Or would you recommend he uses the gum every 12 hours for the first 1 to 3 months? I'll give you 10 seconds to choose the correct answer. So both answers B and D are correct in my opinion. I would advise him to chew the 4 mg since he has smoked more than 25 cigarettes daily, and also to use the gum every 12 hours for the first 1 to 3 months of replacement therapy. Now, NRT using nicotine gum requires specific patient counseling to ensure good outcomes, to ensure efficacy. Now, for patients who smoke more than 25 cigarettes daily, they should be advised to start with the 4 mg gum rather than the 2 mg gum. Now, I would like to emphasize that a new piece of gum should be used every 2 hours at as fixed dosing schedules as possible for the first 1 to 3 months of use. Now, patients should be counseled to chew the gum slowly until a peppery or minty taste emerges, at which point the gum should be packed or tucked between the cheek and the gum to facilitate nicotine absorption through the oral mucosa of the patient. Now, while using the gum, acidic beverages such as coffee, soft drinks, and so on and so forth should be avoided, since they may reduce the amount of nicotine absorbed, and that makes answer C wrong. Then I would like to emphasize that patients should be counseled that combination NRT is now considered the standard of care for using NRT and should be recommended as initial therapy when NRT is chosen as an option. I'd like to remind you that NRT consists of numerous different dosage forms of nicotine. Now, for patients selecting one of their NRT components as the gum, specific counseling points should be emphasized by you, the healthcare provider. And this includes the dose of the gum selected based on the number of cigarettes smoked daily, chewing technique, which is very important, the duration of therapy, and should also remind them to avoid acidic beverages 15 minutes prior to and during the use of the chewing of the gum. I would also like to remind you that smoking cessation in pregnancy is a complex issue, and that NRT is a reasonable option for some patients after a process of shared decision making with a pregnant lady or pregnant patient has been undertaken. That's just by the way. Let's move to the next slide, please. Your clinical team is screening Mr. WCO, a 55-year-old male patient, for initiation of pharmacotherapy to aid him in smoking cessation. He has a history of cardiovascular disease and depression. So my question to you is, which of the medications listed below would be the most appropriate for Mr. WCO now? Would it be bupropion? Would it be clonidine? Would it be buspirone? Or would it be clonazepam? I'll give you 10 seconds to choose the correct answer. It would be. Now, according to the American College of Cardiology, the ACC guidelines, varenicline is the first-line pharmacotherapy for smoking cessation in patients with cardiovascular disease. However, for patients with a history of depression, bupropion is effective in smokers with or without depression. Now, since bupropion is FDA approved for smoking cessation and is similar in efficacy to NRT and is effective in smokers with or without depression, in my opinion, bupropion would be the most appropriate option for Mr. WCO. Now, alternative B, clonidine, can be used for smoking cessation. However, it isn't FDA approved. Now, as a second-line agent, clonidine may be considered in patients who can't tolerate first-line agents. So in this particular case, it wouldn't be our first and best option. Now, alternative D, clonazepam, is a benzodiazepine and shouldn't be used as a smoking cessation agent. I would like to add that buspirone has been studied for smoking cessation. However, it isn't recognized by the American College of Cardiology, and it isn't an appropriate agent in Mr. WCO's case. I would like to add that bupropion is an agent that is both effective for smoking cessation and may help treat certain disorders such as depression. Now, for smoking cessation, bupropion should be used for 12 weeks. However, it may be continued for up to 12 months for this indication if need arises. That's just by the way. Let's move to the next slide, please. Patient reads, Mr. M.A.K., a 69-year-old male patient, is admitted to your hospital for the management of acute myocardial infarction, MI. This is his day 2 of hospitalization, and he has already received a coronary stent placement through PCI in your cath lab, and appropriate secondary prevention pharmacotherapy has also been initiated. Now, on reviewing his medication chart, the clinical pharmacist discovers this particular patient, M.A.K., smoked 30 cigarettes daily prior to his admission for the past 30 years. Chain smoker, indeed. Now, despite the fact that Mr. M.A.K. consents to smoking cessation counseling during his admission, he requests for NRT to be initiated as soon as possible to resolve his cravings for cigarettes and his withdrawal symptoms. To you is, which of the therapeutic options listed below is the most appropriate smoking cessation treatment plan for Mr. M.A.K. now? Would you opt to use nicotine lozenges, 2 milligrams, to be specific, PRN, or would you settle for a nicotine patch, the 21 milligram nicotine patch, together with the 4 milligram nicotine gum for breakthrough craving? Or would you settle for the 7 milligram nicotine patch co-administered with the 2 milligram nicotine gum for breakthrough craving? Or would you settle for varenicline? I'll give you 10 seconds to choose the correct answer. For the 21 milligram nicotine patch alongside 4 milligram gum for breakthrough craving for nicotine. Now, combination NRT is now considered the standard of care for using nicotine replacement therapy, and it should be recommended as initial therapy when we settle for NRT as an option. Now, for Mr. M.A.K., based on his smoking history, that is, he smoked over 25 cigarettes per day in the past, the most appropriate option is nicotine patch 21 milligrams daily with 4 milligram nicotine gum for breakthrough craving. Now, I would like to emphasize that the low dose nicotine patch isn't appropriate for Mr. M.A.K. since he smokes over 25 cigarettes daily. Now, the nicotine gum shouldn't be started at the 2 milligram strength, but we should instead settle for the 4 milligram strength for such a chain smoker. Now, varenicline isn't the most appropriate for this patient who has an acute coronary syndrome, and that applies to all patients with acute coronary syndromes, including MI. It is important to differentiate that varenicline may be used, however, in patients with stable cardiovascular diseases. We only avoid it in acute cases, but in stable CVD, we may use varenicline. Now, single NRT with nicotine lozenges on a PRN basis isn't appropriate, so I will not settle for alternative A. And just by the way, I would like to inform you that e-cigarettes used for vaping, it is VAPING, contain numerous excipients which include, for example, if I remember well, propylene glycol, or glycerol products with combination of nicotine flavorings and other chemicals. So that may be used to reduce cravings, but the long-term safety of these e-cigarettes remains pretty much unknown. So I would not recommend them. I'd just like to inform you that they exist in the market out there. Let's move to the next slide, please. And reads, Mr. ZAJ, a 69-year-old male patient, is undergoing evaluation for a course tremor, C-O-U-R-S-E, tremor of the hand, which has just started. Currently, he takes 50 milligrams of metoprolol ER once daily, 25 milligrams of hydrochlorothiazide, 300 milligrams of lithium carbonate orally thrice daily, 5 milligrams of ramipril once a day, 10 milligrams of rosuvastatin at bedtime, 10 milligrams of furosemide once a day, and he supplements potassium with 10 milliequivalents of potassium chloride taken orally once a day. Some of his pertinent lab values include sodium levels of 142 milliequivalents per liter, potassium of 3.7 milliequivalents per liter, the creatinine is 1.2 milligrams per deciliter, and his lithium levels are 1.1 milliequivalents per liter. Two is, which of the medications listed below is the most likely to cause Mr. ZAJ's cause tremor? Would it be the potassium chloride used for supplementation? Would it be the lithium carbonate? Would it be the hydrochlorothiazide? Or would it be the ramipril? I'll give you 10 seconds to choose the correct answer. Lithium carbonate is the culprit in this case. So I'd like to emphasize that cause tremor is a sign of lithium toxicity. Now, older patients may require lower lithium levels in the range of 0.4 to 0.8 milliequivalents per liter of lithium to avoid the neurotoxic effects of lithium, which result in symptoms such as the cause tremor. Now, lithium levels may be increased because of comorbidities such as dehydration, impaired renal function, and heart failure, or even medications that are co-administered such as the ACE inhibitors, thiazide diuretics, and even NSAIDs. And all those can cause a decrease in the clearance of lithium. Now, cause tremor isn't a side effect of thiazide diuretics such as hydrochlorothiazide, and that makes answer C wrong. I would like to add that thiazide diuretics may decrease renal clearance of lithium, increasing the risk of toxicity. So, C is not a direct cause of this cause tremor. Now, potassium chloride, on the other hand, alternative A, isn't associated with cause tremor. Now, this patient's potassium levels are within normal limits, so I would not opt for A as my answer here. I'd like to remind you that cause tremor isn't a side effect of ramipril, which is the ACE inhibitor in this case. Now, ACE inhibitors decrease renal clearance of lithium, which increases the risk of lithium toxicity. Now, remember, lithium may be used in the geriatric population for the treatment of bipolar disorder or as an augmentation agent in treatment-resistant depression. Geriatric patients may require lower lithium levels to avoid toxicity, to avoid cause tremor. So just remember that when you're treating these patients. And many drugs and other conditions can decrease the clearance of lithium further increasing the risk of toxicity. So be very careful in your choice of drugs when lithium carbonate is used to manage these patients. I'd also like to add that lithium is associated with causing hypercalcemia due to the influence on the parathyroid gland. So also remember that for patients with issues related to that gland. Let's move to the next slide, please. And our question reads, Mr. H.A.M., a 75-year-old male patient, is evaluated by his general physician, who states that he has had some falls recently when he attempts to get out of bed or as he stands up from his armchair. Currently, Mr. H.A.M. takes 150 milligrams of venlafaxine ER once daily, 40 milligrams of pantoprazole once a day, 10 milligrams of memantine twice daily, 5 milligrams of apixaban twice daily, and 10 milligrams of buspirone thrice daily, all orally. So my question to you is, which of the medications listed below is the most likely cause of Mr. H.A.M.'s orthostatic hypotension that is leading to these frequent falls? Is it buspirone, memantine, venlafaxine, or apixaban? I'll give you 10 seconds to choose the correct answer. Venlafaxine is the correct answer. I'd like to remind you that venlafaxine is an SNRI which may cause a dose-dependent increased blood pressure. It can also lead to orthostatic hypotension. It can cause syncope, and it can cause other significant cardiovascular adverse events that are of concern to the elderly population. Now, most data out there indicate venlafaxine is of the greatest concern for these adverse effects. I would like to emphasize that memantine is an NMDA receptor antagonist. Now, the immediate release formulation may cause hypertension, and only the extended release form has a small potential for hypotension. That would not be our best answer for this question. Now, buspirone, on the other hand, is an anxiolytic, and it doesn't cause sedation like benzodiazepines, and therefore may help patients at an increased risk of falls or confusion. So it would not be the culprit in this case. And I would like to add that apixaban, which is alternative D, is a factor 10A inhibitor. It isn't associated with orthostatic hypotension. However, patients with frequent falls may be at an increased risk of bruising or bleeds when taking apixaban, so watch out. Now, because of their action on the adrenergic system, the SNRIs may cause significant cardiovascular effects in the elderly population, which includes increased blood pressure, orthostatic hypotension, syncope, ECG changes, arrhythmias, acute ischemia, and even death if they are overdosed. Now, just as a by the way, I would like to add that venlafaxine, which is marketed as Pristiq, Pristiq, is also associated with orthostatic hypotension in the elderly population. So if your doctor preferred to prescribe venlafaxine, just note that the same symptoms or challenges may occur in the patient. Let's move to the next question, please. And it reads, your long-term patient, Mrs. D.O.M., 75-year-old female, has become increasingly withdrawn after the passing of her husband 60 days ago, 2 months ago. This lady, Mrs. D.O.M., no longer participates in joint activities, neither does she socialize with former friends in her neighborhood. Instead, she chooses to nap in her bedroom in isolation. Currently, she takes 6.25 milligrams of carvedilol twice a day, 20 milligrams of tamoxifen once a day, 20 milligrams of lisinopril once daily, 20 milligrams of furosemide once a day, and she supplements potassium with 20 milliequivalents once daily orally, and she also takes 10 milligrams of donepezil at bedtime. So my question to you is, which of the antidepressants listed below would be the most appropriate choice for Mrs. G.O.M. now? Would you settle for bupropion, escitalopram, paroxetine, or amitriptyline? I'll give you 10 seconds to choose the correct answer. Settle for escitalopram. I would like to remind you that the SSRIs are considered first line for the treatment of depression in the geriatric population, such as our lady here, Madam D.O.M. Now, escitalopram or sertraline are generally preferred over other SSRIs because of more favorable pharmacokinetic profiles, fewer adverse drug interactions, and less risks of adverse effects. Now, bupropion, alternative A, is used for the treatment of depression in the geriatric population when they can't tolerate SSRIs or if they don't respond to SSRIs. It can be used alone or as an augmentation therapy. Now, since our patient here is initiating therapy, an SSRI would be considered first line because we know that they've not yet failed. It is CYP2D6 inhibitor, if I remember well, this bupropion, and it should be avoided in the case of Madam D.O.M. because she's on tamoxifen, and it should also be used with caution because she's also taking carvedilol. Both drugs interact with CYP2D inhibitors. Now, alternative D, amitriptyline, is a tricyclic antidepressant, and TCAs should be avoided in the geriatric patients due to increased risks of adverse effects, which include ECG changes such as the QRS widening. They can also lead to orthostatic hypertension, which increases the risks of falls. They can also cause cognitive impairment. They can cause anticholinergic side effects. Now, alternative C, paroxetine, is an SSRI, but is also a strong CYP2D6 inhibitor. It should be avoided in patients who are taking CYP2D6 substrates, which include tamoxifen, and it should also be used with caution in patients who are on carvedilol. There are major drug interactions between paroxetine and both tamoxifen and carvedilol, so it would not be the best option for our patient here. Then alternative B, in my opinion, would be okay. Now, a related drug, citalopram, is known to be associated with dose-dependent increases in QT prolongation, especially in the context of an overdose. So even as you settle for escitalopram in this case, watch out for dose-related side effects. The QT segment may be prolonged if you use extremely high doses. Let's move to the next question, please. And it reads, Mr. DJT, a 76-year-old male patient, is brought to your hospital by his concerned relatives. He has a past medical history of Alzheimer's, dementia, type 2 diabetes mellitus. He is hypertensive, and he also suffers from hypercholesterolemia. They seek to have his increased aggression towards them addressed by your clinical team. These family members say it is making it difficult to appropriately care for Mr. DJT. They state that episodes present without warning and may even occur when DJT is alone. Very dangerous indeed. The family members say that behavioral therapy helped for a brief period, but after the therapy, he still has frequent episodes of aggression. Currently, he takes 500 milligrams of metformin orally with breakfast and dinner, 10 milligrams of memantine twice a day, 10 milligrams of donepezil once a day, 10 milligrams of citalopram once a day, 20 milligrams of lisinopril once daily, and 20 milligrams of simvastatin at bedtime. The physician plans to initiate a medication for Mr. DJT's behavioral symptoms associated with dementia. So my question to you is, which of the medications listed below would be the most appropriate for Mr. DJT now? Would it be olanzapine? Would it be risperidone? Would it be ziprasidone? Would it be clozapine? I'll give you 10 seconds to choose the correct answer. So risperidone would be the best bet. Now risperidone is an atypical antipsychotic agent which has the most published data in the geriatric population. Now in Mr. DJT's case, the ideal antipsychotic would be the one that causes minimal effects on his blood sugar, his weight gain, and even lipids because of his type 2 diabetes mellitus and his dyslipidemia. Now, he is also on the maximum dose of citalopram for a geriatric patient, and caution should therefore be used with any agent that would increase the risk of QT prolongation. Now, risperidone can be used for agitation or psychosis in individuals with Alzheimer's dementia. It is more likely than other atypical antipsychotics to be associated with hypercholesterolemia. I would like to remind you that risperidone may cause weight gain, diabetes, or dyslipidemia, but less likely than olanzapine or ziprasidone. Now, risperidone is less likely to cause cognitive impairment than other antipsychotics like olanzapine. Now, while ziprasidone has less effects on glucose, lipids, and even weight and cognitive function, data with ziprasidone is limited in the geriatric population, and it remains the antipsychotic most associated with QT prolongation. Now, since this patient is on the maximum dosage of citalopram for the geriatric category or population, any agents that could increase the risk of QT prolongation should and must be used with caution. So I would not settle for ziprasidone in this case. I would like to remind you that olanzapine and clozapine are associated with the highest risk of metabolic complications in the geriatric population as compared to other atypical antipsychotics. Olanzapine, to be specific, may worsen cognition and even increase the risk of delirium in patients with Alzheimer's dementia. So be very careful before you opt to use it in this population. Now, I would like to emphasize that olanzapine is a CYP1A2 substrate, and its use with CYP1A2 inhibitors may cause or may increase the risk of adverse effects. Now, clozapine use in the geriatric population is limited by its hematological, anticholinergic, cognitive, metabolic, and even cardiac adverse effects. Now, regular monitoring of absolute neutrophil count is required during initiation and treatment with clozapine if you opted to use it, though I would not opt to use it in this particular patient. Now, most data support the use of clozapine in the geriatric population for the treatment of primary psychotic disorders or drug-induced psychosis in Parkinson's disease, not in Alzheimer's disease. So that makes it the wrong drug in our case, because we do not have a case of PD, but our patient has Alzheimer's dementia. I would also like to add that risperidone is also available in the parenteral formulation, which is made up of microspheres, and this allows for a bi-weekly and every weekly dosing regimen, which is administered via IM injection, PRN. So, my highly esteemed viewers and listeners, that brings us to the end of this video. Now, if this video benefited you in any way, please remember to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and your very kind collaboration, and I look forward to interacting with you in part 67 of our MCQ series. Thank you very much.